Our next speaker is Marie Chantal. There she is. I can see her. Hello, Marie. As people know, she's a physician, also a friend of the project. She has a strong interest in legal, ethical, and policy issues in this realm, and she is going to tell us about stakeholder perspectives on the use of precision medicine in this context. It's going to fit in so well with the discussions that we've already had. Over to you, Marie Chantal.
Okay. Good afternoon, everyone. Can you see my screen? Is it okay? And can you hear me?
Yes.
Is it okay?
Yes, we can hear very well. Thanks.
And you see my screen. It's okay?
Yeah, we can hear you perfectly. Thank you, Marie.
Okay. Thank you very much. Well, so good afternoon, everyone. And I would like to thank you for inviting me to present the work that we have done in Can Prevent. So today I'm going to present the stakeholders' perspective on precision medicine in kidney transplantation, and I think it follows very well. It's a good Louisa has put the table to follow on my presentation. So I have no conflict of interest to disclose, except that I am a transplant nephrologist and I'm interested in all innovation that will improve my patient's life and patient graft survival. So as you all know, kidney transplantation is the best treatment for patients with end-stage kidney disease. However, the long-term graft survival is not perfect, and there's a lot of graft failure after 5 and 10 years. So it varies, but that is significant. These are the Canadian data. So, well, it's why that we have to find some solution to improve our graft survival. As you all know, antibody-mediated rejection is a major cause of graft loss, and we don't have any effective treatment currently available, and it is associated with the development of donor-specific antibodies. Kidney allocation, it's just a reminder. This picture is from a paper published in Cambridge Quarterly of Healthcare Ethics, but it's always a balance between equity or fairness and efficiency or utility. So when we want to consider fairness, we take into account ancestry, ethnicity, HLA sensitization. So we have a good example here in Canada with our highly sensitized program where we give priority to patients who have a CPRA over 95% to give them advantage to get a transplant since they are already disadvantaged. When we are taking into account waiting time or time spent on dialysis, geography, well, we don't take into account, but socioeconomic status could be taken into account to improve fairness and also blood type. When we balance utility, well, we could maybe anticipate years add to life, try to allocate kidneys to people who will have the best graft survival or the best quality of life after transplant. Try to allocate based on age. It's what happened when we give priority for young patients over older patients. And we could try also to avoid wastage. It's what we are doing when we try to use all kidneys for all patients. Molecular-based matching, it's only a reminder, but I think you heard a lot. That's a more precise method for assessing HLA compatibility, and it could potentially increase graft survival. So, of course, there are ethical challenges of molecular matching. There's potential benefits of improving patient survival and reducing graft rejection, so to improve medical utility. But there's a lot of uncertainties related to molecular matching. There are also many fairness concerns. There's a risk of reduced access to transplantation for some patients with rare epitopes. So The objectives of my part in Can Prevent was to gather key stakeholder perspective on molecular matching and precision medicine in kidney transplantation. So the key stakeholders were transplant professionals, transplant candidates and transplant recipients, and HLA experts. For so, we used a qualitative study. We conducted semi-structured interviews with patient, kidney transplant professionals, HLA directors. We developed an interview grid, and the themes that were present were knowledge and opinions on the current allocation system, the role of molecular matching in disease and living kidney donation, and informed consent and molecular compatibility. We use a qualitative description approach, and we also use in vivo to help us in the qualitative analysis. So here you have the patient characteristics. As you can see, we have performed 27 interviews. Most of them were kidney transplant recipients. We had a few kidney transplant candidates, and we have some caregivers who were interested in this study and who participated in that study. Most of our patients were recruited at the SHIM and at the MUHC transplant program. However, we also used the social media, the Facebook page of the CDTRP and also of the Kidney Foundation, and that's why we had one patient in Ontario, in Alberta. Well, a little bit more female participants were in their 50s. They were mostly white. They were employed or self-employed or retired. They were highly educated. And for patients who were transplanted, time since transplant in average were 8 years, but the range was 1.8 to 32 years since transplant. And for kidney transplant candidates, 4 of them were on hemodialysis and 2 on PD. So their perspective and knowledge of the current allocation system. Many patients told us that they have limited knowledge and they needed more information. I think this quote is really evocative. It was a kidney transplant recipient who told us, "I understand that there's a point system out there. No one will give you a straight answer on how the point system works. It's like a big secret in the world of transplant. So if we educate people more in regard to what the process is and what they look at and how they can be like how we can help with the process, that's why I think it's so important to do this thing." That being said, although they report limited knowledge and need for better information, they trust the system and they describe it as fair. For most of patients, immunological compatibility and graft survival were the most important criteria to consider. However, they also mentioned adherence, time spent on dialysis, and lifestyle habits to be considered in kidney allocation. It's interesting because in the current system, we don't want to consider social value. However, there's a lot of studies that have shown that for patient adherence and lifestyle habits are important factors to consider in kidney allocation. Precision medicine is an interesting way to allocate organs for patients since it could improve graft survival, prevent graft rejection, and make the healthcare system more cost-effective. So one patient would say, "I think that's wonderful. I mean, if they can match you better and it lasts longer, I think that's the goal, right? We want to do it and make it last as long as it possibly can and let the person have the healthiest life for the longest amount of time without having to go through another surgery, another waiting list." However, they expressed concern in terms of decreasing access to kidney transplantation and increasing waiting times. So my reaction right away was this: whenever you target it as precisely as possible, you have a better chance of success. There's no question. However, if that takes more time, if that restrains a person from getting it when they really need it, then that's my concern. I think ethically you can just rely on that. Is that just even a bigger level of discrimination too? It was a quote from a caregiver. We asked patients also what would be the role of precision medicine in living kidney transplantation. They mentioned that it was potentially useful for identifying the best donor or inviting compatible pairs to kidney pair donation program. However, they had also mixed feeling because, well, they mentioned that they would prefer for receiving or donating a kidney to their loved ones. And also the concern that if we include precision medicine in kidney pair donation, it could also increase waiting time for finding a compatible pair. So the issue of the preference for receiving or donating a kidney to their loved ones was also something mentioned in previous studies that we conduct with the recipient and donor when we asked them about inviting compatible pairs in the kidney pair donation program. Patients also identified mitigation strategies and formulated recommendations. The first recommendation was setting a maximum waiting time for a molecular match kidney. For them, the maximal waiting time will be a total of 4 years or 1 of 2 years above the average waiting time. That would be acceptable. Also, they mentioned they were concerned about the difficult situation of a highly sensitized patient. So for them, highly sensitized patients should have access to the current programs in addition to the molecular match kidney, and they should take, the first kidney that is compatible. Also, it's important to develop educational tool to be sure that, patients are able to provide informed consent. And also for patients, it's also important, transplantation is important, but they wanted also to mention that it's important to pursue research on renal replacement therapy that will improve patient health and quality of life while they are waiting. So all of these results are currently under review in a manuscript in the clinical transplantation. In the next slides, I will present you the results with the kidney transplant professionals. These results were published in Transplantation Direct in this year. So we conducted 17 interviews with transplant professionals. Here you have the details. Most of them were transplant nephrologists, adult transplant nephrologists, and they were coming from the different regions of Quebec, not of Quebec, of Canada. And they in general, in average, they were involved in nephrology for the last 16 years. One of the first themes that was reported by transplant professionals was the importance of fairness and equity in kidney allocation. For many participants, fairness and equity are more important than medical utility, since it is part of maintaining trust in the allocation system, and the allocation system should strive to increase access to kidney transplantation.
Blackmore Pavilion, 5 Alpha. Code blue, Leon Blackmore Pavilion.
Sorry, Marie, Chantal, we have an emergency.
Yeah, there's a code blue.
Just a message. It will be over in a moment.
Okay, no problem. I'm used to that. So
there you go.
So one quotation from a transplant nephrologist was, so for me, maximizing access to transplantation outweighs maximizing the longevity of transplanted kidney. It's more important. And for a pediatric transplant nephrologist, he told us that I think from a programmatic perspective, the health system needs to be biased toward fairness And so, you know, as it relates to the default position, it should be to ensure that everyone has a similar access to transplantation and that the choice to wait longer for a better match kidney or better quality kidney should be the choice of the transplant candidate, not of the system. For other participants, both fairness and medical utility are equally important. So for one transplant nephrologist, it's ideal to strike a balance between equity and utility. And another transplant nephrologist mentioned also the need to, I think a balance needs to be maintained, because if we just consider graft survival, we'll no longer transplant older people, and older people have the right to transplant as well. Molecular matching is also promising innovation for transplant professional, since it could increase the medical utility of a limited pool of organ. So one transplant nephrologist would tell us, I think that the concept is obviously very attractive. So, and if we back it up, so the premise here is that unlike serological typing of HLA antigens, that matching on epitope load or epitope mismatch may allow us to increase the utility from the available organ supplies. And here's the key: without exacerbating disparities that are linked to genetics, which are ultimately linked to race. Molecular matching could also reduce the risk of antibody-mediated rejection and the need for potent immunosuppression. It could also, so one transplant nephrologist told us, basically, I think it's great, especially if we can have a kidney that can be better matched, meaning fewer rejection, fewer immunosuppression. Also, molecular matching could be used for patient monitoring. It could help also to choose among many living kidney donors. And there are benefits of molecular matching for young recipients, since we know that they will need many transplants in the future, and we want to minimize the development of donor-specific antibodies. Concern, of course, where the potential increased waiting time, which could be particularly salient for disadvantaged populations, such as ethnic minorities. And one transplant nephrologist will tell us, and we know for a variety of sort of socioeconomic and cultural reasons, that there are certain minority groups that are underrepresented in the donor population. And that means that certain minority group will be disadvantaged if we prioritize too much. Also, informed consent. It will be hard to get informed consent from patients on this complex issue, and we should develop educational tools that are easy to understand. So, for one transplant nephrologist, we will have to put it into extremely easy to understand lay terms, because no one is going to know what we're talking about if we mention epitope matching. Another transplant nephrologist told us, I think if we are going to provide them with too much complex information, they will get confused and maybe a little scared, to the point that they may actually run away from transplantation. So I hope that someone will be able to maybe create a cartoon on HLA. They also mentioned concern about the logistic and the operationalization of molecular matching. For one transplant nephrologist told us, I think we will get there, but I think there is, as I said, when the labs are already struggling financially to do the testing we are doing just now, it's tough to see us getting there in the next year or two, and the technology is still evolving. They also formulated some recommendation before implementing a molecular matching allocation. The first recommendation was the maximal waiting time. For instance, so remember, for patients, it was maybe 4 years. So for transplant nephrologists, it's a 5-year maximum time. So one transplant nephrologist told us that I think that for people who have waited 5 years, it's their turn. So I think that could be integrated, but with an eye to ensuring that there's a maximum number of points that they can collect, and that this doesn't hinder people who have been waiting a long time for a kidney, even if it's not as well matched, because it still works and it's still going to improve their quality of life, even if they aren't matched and they have a higher risk of rejection. I think that if we can help without adversely affecting certain patients, respect a reasonable wait time while better matching kidneys for others, I think that could be acceptable. Also, molecular matching-based allocation should be implemented at the national or international level in order to expand the donor pool. So, again, absolutely, that is a risk that if you don't have, or if you are going to wait longer and longer and longer and not get your mat, but if you could expand the donor pool to the entire country, then you are just increasing the number of lottery tickets everybody has to potentially get those epitope match. And also, there's a need to involve stakeholder and to be transparent. So for one transplant nephrologist, we have to bring all the relevant science and data to the discussion, plus having all the relevant stakeholders at the table, plus making sure all the relevant information is intelligible and can be used by all stakeholders effectively. Because if the physicians are the only ones who understood that part, then we fail. We have to make sure the patients also understand, at least at a reasonable level, what this information or what these data are telling us about, for example, the effectiveness of epitope matching and so forth. And then again, using guiding principle frameworks that allow us to think clearly about the problem and the issue of resource allocation and scarce resources. So in the next slide, it's really new data that I'm going to present. We have completed the analysis last week. We conducted 7 interviews with HLA experts. We have invited the 21 HLA experts in Canada, but 7 agreed to participate. Here you have their characteristics. Most of them were in their 50s. And the majority were the HLA lab director, and they were coming from different regions. And in average, they had 17 years of experience in nephrology. If we ask them about the current allocation system, they had a generally positive perspective, but some of them suggested that there's room for improvement and optimization for more fairness. So one of them would tell us, yes, it's an algorithm that's been in place for several years now and needs to be optimized. So there is perhaps a certain level of inequity where we should perhaps have more of a gradual scale. They also identified different challenges. First of all, lack of resources, lack of HLA staff, higher resolution testing, and also challenge in terms of logistic, IT limitation, need for comprehensive data, better models, and research. They had also concern about disparities for minority group due to insufficient testing of tools like epitope analysis. And one told us, it doesn't work well for all ethnicities. I mean, minorities tend to not work well as well when it comes to epitope analysis. So in general, these tools are not tested well with minorities, and so we should be mindful of that as we design what are the future studies we are doing. Again, they mentioned that it's important to educate and involve clinician, expert, and patient. So one of them would tell us some physician may not even know what an eplet is, so you need to educate them before they can even have the discussion about how to change the algorithm. And another one would say, so therefore, I think that allocation committee should involve patient in there as well, and the patient, their perspective, they will say how much they suffer from this dialysis and what complication they have. They also recommended pilot testing program before widespread implementation across Canada. So it is I report here the first studies that report transplant professional patient and HLA professionals' perspective on precision medicine in kidney transplantation. Here is a table that summarizes the similarities and the difference between the three groups. It was interesting to see that for patient, medical utility is more important than fairness in allocation criteria. And for transplant professional, fairness was mostly more or equal than medical utility when you have to design allocation criteria. And for HLA expert, they had mixed opinion, with the majority suggesting a combination of both. For all three stakeholder, precision medicine and molecular matching is a promising and innovative avenues in kidney allocation, since it could improve graft survival and personalized treatments. However, they expressed concern about decreased access to transplantation for some patients, such as ethnic minorities, and increased waiting time. And patients and transplant professionals suggested setting a maximal wait time for these matched kidneys. So also, I think it's interesting to see that there's a paradox with precision medicine. We strive to have a more precise allocation. However, there are many uncertainties related to this clinical application. And I think it's really interesting to see that transplant professionals and patient perspective and also HLA experts are aligned with the result of a pan-Canadian deliberation where participants supported molecular matching. So I will not go into details because we've already presented this. So of course, our three studies have have limitation. It was small samples, but however, we achieved data saturation. Patients were mostly white and highly educated. I just want to mention that patients, when they participate, I forget to mention that before their interviews, they had a PowerPoint on epitope matching and allocation criteria to be more educated and to be able to participate in the discussion. However, we didn't make any educational tool for transplant professionals, so their perspective were based on their own knowledge on the subject. And I think one thing that is missing with our study is that we did not capture parents' perspective for molecular matching in pediatric kidney transplantation, because pediatric patients are the one who could benefit the most improving kidney allocation, since they are at high risk of AMR because of a high prevalence of non-adherence, and also they will need in the future other transplantation, and we want to prevent the development of donor-specific antibodies. So the take-home message is that precision medicine and molecular matching are promising innovation in disease and living kidney donation for patient, transplant professional, and HLA expert. That maybe we should set a maximal waiting time, and it's important of engaging different stakeholders, and I think the public deliberation was a way to engage different stakeholders, and also the importance of developing educational tools based on patients' need to be sure that they will understand this new allocation, and again to be sure that allocation is not a big secret as mentioned by one of our patients previously. So I just want to thank my research team who was really who worked hard on this project, and also the funder, the Genome BC and Canada. So thank you very much. I'll be glad to answer your question.
Thank you very much, Marie Chantal. I love the idea about the cartoon. I think that's a great idea. And I also love your comment about the precision paradox. I think that is so true. Questions? In the audience, we got time for...
I'm sorry to not be there in person. I know it's more lively when you are in person, but with family obligation, it was hard to travel to Vancouver for 2 days.
Paul.
Thank you, Marie Chantal. That was great. Not so much a question, really more a comment. I think this question of a certain time limit and then expanding the opportunity is one that I hear resonating everywhere. So we have talked about a time limit of maybe 2 years, but what do you think from your side of the country?
From our side of the country, it was interesting to see that patients were keen to wait 1 or 2 years above the median, the average waiting time. So our average waiting time for a group A is around 2 to 3 years. So for a B group, it's more than that, but we didn't go in, the details with patients, but it was. And again, we didn't explore the issue of age, because maybe if you're 70 years old, you cannot wait for a long time for a better match kidney. So that would be okay to, the objective would be to be off dialysis and not get the best kidneys. But but the patient who participated in our study, since it was easier with all to get, REB from McGill and the CHUM, so they were from Montreal and from Quebec, but we didn't have the expertise, the perspective from patients from the rest of Canada. But for transplant professional, it was 5 years, the maximal waiting time.
If I could just add one more comment, maybe there's a way of incorporating the data that Ruth showed us this morning and have some sort of graduated liberation, if you like, so that by the time you get to X point, if you've not been transplanted, the flexibility allows a sort of slightly larger epitope mismatch, and then that can happen until you get, you get the next kidney which comes along.
That was my question. Sorry, I put my hand up to ask a question too. So the practicalities of how, because I think intuitively I like that idea of a time limit. Also, it feels like it creates this balance between fairness and utility. How would that work though? So once you hit the 2-year point, is it just a shift in criteria? Is that the idea, Paul?
So for BC, our average waiting time, James may give us more information, but it's somewhere around 2 years to transplantation. So we had talked about saying if you get to 2 years and you've not been transplanted, you simply get the next kidney that comes along or something like that. But it may be that a graduated approach for, different sites across the country have different
waiting or something like that. Okay, I'm looking at the boss. Are we done? Marie Chantal, thank you so much. It's so nice to see you, and everyone's waving, and appreciate all the work that you've done. And I think we're right on time, if I'm not mistaken. Right, we have a half-hour break now. Is that right? Oh, go ahead, James.
I was going to say there might be an opportunity about how to do it is that when we model out the BC donors, because donors donate 2 kidneys, and it wasn't always possible both kidneys could actually go into a well-matched patient. So one could consider a scenario where you would give 1 kidney away to someone who's well-matched, and the other one you could give it to someone who has already waited more than a maximum 2 years, let's say, and then they just go to the top of the wait list and then they get the other one. So I think from an allocation policy perspective, we could actually have a flexible way to accommodate both.
Interesting idea.
That's a good suggestion. Of course, we have two kidneys, so.
Okay, excellent. Thank you so much, you guys. Is there any other things that you want me to pass along? No? Oh, sorry, Ruth, I didn't see you there.
Red and not very obvious.
You're always obvious, Ruth.
Thank you. It's always good to have a voice and to use it every now and then. So just a point of note, we could predict, knowing the composition of the donor pool and the patient's HLA type and blood group with regards to their likely access. I mean, granted, some people get the draw of luck, but many times we can predict it in advance. This is the whole idea behind the CPIE that takes blood group and molecular compatibility into consideration. And in that context, we don't have to make decisions and pursue informed consent in that time and moment under duress, but rather we could inform patients in advance that they may be expected longer than the average waiting time. And there we can both confirm their agreement to accept a transplant with a higher immune risk, or find alternatives that we can do again with solutions at the national or regional perspective. So implement equity parameters to facilitate access, or alternatively, maybe living donation might be the solution.
Excellent. And I think that plays into the data that we just heard of transparency, open, and patient participation in the decision making. So thank you very, very much. I think we're meeting